Hello, everybody. We're about to get started with today's session. We have Dr. Ankeny, who's a surgical oncologist at the University of Minnesota. So I'll just let him kind of introduce himself, and then the way we'll kind of just go is you can take as long as you need to answer the questions, and then if we get more questions in the chat and stuff like that, we can just kind of go back and forth from asking you.
Hi, everybody. I am Jake Ankeny. I'm originally from Minnesota, from southern Minnesota in Blue Earth. It's a really small town. I went to undergrad at the U and I went to medical school at the U. And then I did my surgical residency at UCLA in California and my surgical oncology fellowship at Moffitt Cancer Center in Tampa, Florida. And I've been a faculty here now for a little over a year. My specialty is surgical oncology, and I specialize in pancreas and liver cancers. So happy to answer any questions or go through anything you guys want to go through.
Before we start, can you talk about what oncology is, what your day-to-day routine is, and also if you want, this is your choice, talk about what how did you, because you went to the University of Minnesota medical school, and that's a pretty good medical school, what did you do to help your application, what were your steps, and how was your journey to get into medical school?
Yeah, a lot of questions. So first of all, I'll start with the first one. What is oncology, right? Is that what it was?
Yeah, okay. And also what your day-to-day routine?
Yeah, I mean, oncology has two or three, it's really the study of, oncogenes that end up leading to cancer. But, in clinically speaking, it's just taking care of cancer patients. And it has several branches. There's radiation oncology, which is a real technology-based field, which focuses on all kinds of physics and technology associated with delivering radiation with imaging guidance. So that's radiation oncology, and that in and of itself is a whole residency and specialty. So that's a pretty cool area. And then there's medical oncology, which is really specializing in targeted therapies and chemotherapy and that aspect of oncologic care. And then surgical oncology, really what I got training in is all of those things, because they ask you about all of those things on your boards for surgical oncology, but your goal really is to determine how surgery fits into an overall treatment plan, or not. And if it doesn't fit into that treatment plan, what might fit into that treatment plan. So it really spans the gap between surgery, medicine, radiation oncology, and even quality of life fields like palliative care, and hospice care and things like that. So that's really what I do, my job on a day-to-day basis. I'm 60% clinical and 40% research. So 2 days a week, which right now are pretty variable because of COVID and we don't have any OR block time. But 2 days a week, essentially I get time to do administrative or research related things. I do have a lab. It currently has nobody in it, but that's okay because we can't start anything right now anyways. But essentially, you can't do research by yourself when you only have 2 days a week. So, the Department of Surgery, when you start these, typically starts you with a research package. And you get funds in order to maybe hire a tech and have initial funding and things like that. So essentially, the people that actually do work are the techs that I pay for, or interested medical students or residents. And that hasn't gotten full-fledged, or that hasn't gotten going fully yet because I'm only a year in, and there's been a lot of challenges with doing that. So that's essentially what it looks like. You don't typically end up doing a ton of the research yourself, but you hire people to do it. What you spend more of your research days doing is maybe going over data from the prior week, or writing grants, reading papers, things like that. So that's what most of my time consists of on research days. On clinical days, I have 2 OR days a week, and I have 1 clinic day. And on the OR days, I typically, because it's liver and pancreas, I end up doing 1 case. Sometimes I'll throw on a second very short one. But, a lot of our cases take, 5 hours or more. So that's my days for the OR. And my day for clinic is on Friday, and it's a full day of clinic. So basically, I guess my routine week would be Mondays. I typically have nothing, so it's typically a research day. I'll often show up to work at maybe around 8 o'clock. What I do first is I go through the medical record and I figure out if there's anything that I have to deal with regarding outpatients, anybody that I saw, whatever it might be, any inpatients that are in the house. So I spend the first maybe hour or two doing clinical things in those days. Unfortunately, you never get away from it. So I do a couple hours of clinical related things, and then the rest of the day I do research related things, which is, like I said, writing or going over data or having meetings with other labs or whatever it might be. Tuesday is typically an OR day for me. So usually my cases started around 7:45. So I usually show up to work around 6:45 and make sure that I've seen all my patients if there are any in the hospital, make sure any urgent issues are taken care of, and then I go to the OR for the day. Wednesday is another research day, so it's much like Monday. Tuesday is another OR day, and then my clinic days typically start at 9, but we have an educational conference from 8 to 9 every Friday. So that's what my week looks like. Definitely much earlier hours when you're a surgery resident than when you're an attending, which is very nice. Hours are very manageable, very nice. You will have some clinical mix every day because you're going to have people in the hospital. And you're going to have a mix of clinic and surgery and research if you decide to do an academic tract. So it's got nice variety. It's fun. It gives me plenty of time with family, plenty of time to, like right now I'm technically, I don't know if you can count babysitting your own kids as babysitting, but right now my kids are home while my wife is getting her dentist appointment today. So it gives you plenty of time to do the things that you need to do. I probably missed some questions in that first stream, but what didn't I touch on?
You touched on most of them, so thank you. But one main one that we're also getting in the chat is what led you to choose, like, out of all the specialties, surgery, and then what about like oncology was really like what really kind of drew you to it?
Okay. I think what draws me, it's weird. Oncology will draw people that for whatever reason develop develop relationships with the patient. What do I mean by that? A lot of people find oncology hard because it's one difficult conversation after another. I have a strange, sick attraction to patients who are having a hard time. I always have. I don't know why. I can't say that I have too much personal experience with it myself, so I don't know where that comes from, but I think you have to have that to go into the field, and I always had that. So I always think I was going to do a field that had a lot of difficult conversations, whether that was palliative care or oncology or whatever it was. I was always drawn to that. The other thing is I've always enjoyed translational research, and it's a field ripe for that opportunity. And it's really challenging because, you're trying to solve puzzles, especially with liver and pancreas cancers that, in 40 years, we haven't made much progress on. So it's extremely challenging. And then the surgery part, I kind of always had a feeling I would do. I went into medical school wanting to do orthopedics. It was my very first rotation, and I actually hated it. So I was very quickly in that space where I didn't know what I wanted to do. So a lot of my third year, I thought about doing something like cardiology, or an interventional cardiology, something like that. And then there was actually a time when I was thinking about doing gynecologic oncology, just because I had done some research in the past and I really enjoyed the gynecology and the gyn-onc rotation that I did. It was an elective. And then I did my general surgery at Hennepin County. that actually kind of, I didn't ever have general surgery on my radar, but that kind of married a lot of the things that interested me. I could do oncology. It was very broad, so it was flexible if I decided not to do it. And that's really how I decided. I had a lot of fun at Hennepin County. I liked the area. It married with research. And then the oncology thing, I think, came naturally with research and then just me being drawn to difficult scenarios for whatever reason. And you guys asked about applying, or what did I do to get ready for that? Didn't you ask
Yeah,
that?
what do you think like made your like application stand out into like I don't
Yeah,
know. I've heard University of Minnesota like pretty competitive and stuff.
yeah. So the thing is 1 second. Oh, can you give me just 1 second? Gotta
Yeah,
just
that's
put out a
fine.
fire.
Yeah, definitely.
Put this over here. Yeah. Okay. Here. Why don't you come over here? Go play with that over there.
If you guys want, you guys can ask questions in the chat or like raise your hand and we'll like unmute you guys so you can ask them like yourself too. It's up to you guys.
Okay. So we're going back a little bit because it's been 11 years since I graduated medical school, but and 15 years since I went into medical school. But what I would say is University of Minnesota is a really great place to study, period. Whether you're undergrad, whether you're in medical school, whatever it be. The disadvantage, yeah, you may not have the pedigree of Harvard. You may not have the direct on-hands learning that you get from a place like that. You may not have the monetary endowment to do all the things that you want to do. But it's wide open. I found the resources to be unlimited if you go after it. And I think anything is possible. It's just a place where you have to make your own connections. Nobody's going to do it for you. So that's the one downside to the U, is if you are a system type person where you really need like a list of things you can do, or it can be harder at a place like the university to really stand out. But if you think you know what you want, and you go after it, and you seek research opportunities, and you seek mentorship to help you get to where you want to get, the University of Minnesota is no hindrance to your record. Nobody's going to look at the University of Minnesota and say, we're not going to let them in because they're from the University of Minnesota. I had a lot of luck with getting into medical school coming out of the University of Minnesota. I had 5 or 6 places I could have gone. I chose the U because it was close to family. And the way I was competitive is you try and stay well-rounded. But even more importantly, I think you have to have a passion. And one thing that I think is difficult about medical school these days is even more and more and more, they're picking on people who are well-rounded. And so I can't stress that enough. It's probably very stressful for all of you to go into this. I'm not sure that I would get into medical school anymore today. And I mean that. The applications and the level of the applicants that are coming through are incredible. But I think the best thing that you can do is get involved in some kind of research that you like, whether that's outcomes, whether that's in a lab, whether that's quality-based, whatever it is, get involved in it. And if you can get involved in, don't just volunteer for the sake of volunteering. Get involved with volunteering in opportunities that really drive your passion. So if you have an interest in global health or something like that, reach out to global health people and see if you can figure out how you could get on one of their global health trips to go somewhere and provide aid or relief or care or things like that. Those types of opportunities, things that fit your passion, things that fit what you want to do, are going to be a lot more helpful than just doing something for the sake of being on your application, because it's so intimidating to think of all the things that you have to do in addition to being a good student and having good MCAT scores. And interviewing, you have to be honest. Don't make up things. Just tell the truth. And if you don't know, you don't know. But I would try and think of an answer for why you want to be a physician before you go to interview. That's the one thing that I would really try and think about, because not everybody knows why they want to be a doctor. You just like it, right? And to come up with an artistic, artful answer as to why that is sometimes hard. But to admissions people, you look pretty dumb if you don't have an answer for it. And that's the best way I can put it. So that's how you are going to be competitive for medical school. You need to do some sort of research. And I know that's a lot. That's a lot for anyone's plate. It doesn't have to be in a lab though. It can be outcomes based. You need to do well in school, and you don't have to get a 4.0, but you need to do well enough that you're not better than, or I shouldn't say, you need to do well enough. And then MCAT score is important. They all look at it. And then some sort of volunteering experience that fits maybe a passion that you have. And usually you can get, like I said, usually you can get involved with direct health-related volunteering. I actually volunteered at Hennepin County Medical Center, but I was an example of just volunteering for the sake of it, which is not what I'd recommend, because I didn't end up doing anything that was that fun or that rewarding. That's why I say, think about something that might be of interest to you and go after it. Because I know there's tons of opportunities now, even more than when I went through.
Another kind of question we've asked other physicians is kind of about mental health. It's kind of coming into the conversation more, and people are kind of bringing more attention to it. How do you, as like a medical student, physician, resident, kind of take care of your own mental health while also dealing with like the stress of your patients and kind of balancing all that on your plate?
Yeah. So to be frankly honest, there's some things that you have to do for mental health. One of them is you have to learn how to say no. And that seems maybe weird at your stage, but you'll find as you go through this whole process of medical school and residency and fellowship, perhaps, if you decide to do that, and along the way, in order to kind of further yourself and give yourself the most possible opportunity, you'll say yes to a lot of things. Some of that will be of your own accord. Some of that will be just the fact that you're the lowest person on the totem pole. And you sort of learn to do that as you go through. And that can become a real problem when you first go out into practice, because you will say yes to everything. Yes, I'll do this seminar. Yes, I'll give this lecture. Yes, I'll see those 14 extra patients. Yes, I'll add on a clinic. Sure, I can cover this Saturday. You'll find yourself doing that a lot. And if you do, you're going to fight mental health issues, because it will become your life and it will swallow you. You absolutely have to be able to get away and leave it and just be able to say no. I wish I could give you a primer and a course on how to do that, but you'll figure it out over time. You got to figure out what you have. Everybody has to do some things for, just to be a good Samaritan. You have to chip in and provide something for the benefit of somebody else and not for yourself. You have to do a little bit of that, but you don't have to do millions and millions of hours of it. You have to do a little bit of it. You have to do the things that are necessary to fit your goals, and you have to do the things that are necessary to fit your family goals. And if you, as dumb as it sounds, if you make a list of those things, you'll figure out what is urgent and important, urgent and unimportant, non-urgent and important, non-urgent and unimportant. and you'll be able to take the things that are non-urgent and not important and either delegate those or skip them altogether. And that's really how you have to categorize your life. You have to figure out, of all the things that I want to do, where does it fit? Obviously, the urgent and important things, the things that you need to do and spend your most time on. And that just matters where your values are and what you value. If family is urgent and important, then you have to treat them that way. And that's how you maintain mental health. There is no doubt about it. You have to be able to say no. You have to be able to set a boundary, or you get swallowed. And the good news about being an attending is you get that opportunity. People tell you a certain amount of things like, we need you to see this many people in clinic and we need you to do this many RVUs. They don't tell you how to do that or when to do it. So it's up to you to kind of create that in your schedule. And if you do, you're going to be super happy. You really will. It's a really nice life. Delegation is key. You have to figure out how to get other people to help you with things that they can help you with. I think a tendency of a type A personality, which is people that go into medicine, is to want to do everything themselves. And if you do everything yourself because you're worried that somebody won't do it the way you want it, or maybe as good as you want it, that's another recipe for a lot of mental health issues. Stress, anxiety, depression, all kinds of things. You have to be able to delegate. You have to be able to tell people what you want and trust them to it. And if you can do that, in addition to learn to say no and prioritize, you're going to have a great career. It's a lot of fun. It's extremely rewarding. The other thing is surgery is a little bit different than medicine. Particularly what I do, there's a lot of things that you do that as a surgeon that directly affect people. Because naturally, if you do a surgery and they have a major complication, that's like a direct effect. That's not just their disease got worse or their sickness got worse. You have to be able to deal with complications. And a lot of that is just talking about them and having partners that you can talk with about those complications. This is a surgery specific thing because everybody gets on a roll where nothing happens and it seems like you're invincible, but then you'll get on a roll of 6, 7, 8 patients in a row that all have complications and it starts to get stressful. So you have to have your posse of people that you can talk to relieve the stress, because it's real and it's sometimes hard. But through that, if you think about it, that's, it's urgent and important, but on your priority list, right? You're still going to put your family and your life and your well-being first. And that's how you fight through those things.
Thank you so much. That was a really great answer. One question we're getting a lot is also about research, and one specific question is, how does medical research differ from PhD research, and does it require any more training?
So the short answer to that is no, but the long answer to that is it's extremely complicated. I'm fighting with that reality right now. If you go through an academic-oriented training and career and don't get a PhD, you will do research along the way. You will publish, you'll get experience in a lab or whatever it is. And you'll get to a point where you can probably figure out a few things at the research bench, which is great. But I also think it's very different depending on what kind of research that you do. Because if you're outcomes-based, oftentimes outcomes comes very natural to you clinically, because it has to do with clinical outcomes and how we know which treatments that we do work the best and have the highest rate of like that comes very natural to a physician. And most physicians end up doing outcomes-based research because of that. What I'm speaking of here is specifically bench and translational research. I think having a PhD matters somewhat. The reason I would say that is because like I said, when you're an MD and you go through this academic track, yes, you get experience of this all along the way, but it's kind of mixed in with clinical stuff and all kinds of other things. A PhD, they spend 4, 5, 6 years on one thing and they perfect it. And during that time, they take courses and they gain expertise. They learn about the techniques that you might need to use in a much higher detail level. And then not only that, but once you graduate with your PhD, most of these people are doing 1, 2, 3, sometimes 4 postdocs. So they might spend another 8 years after their training just gaining additional expertise and training before they even get hired as a professor at a university. So what I will say is the average professor that gets hired at a university that's a PhD versus an MD is much more well equipped to run a lab and write grants competitively, because they just have way more time and experience doing that than an MD does. It comes natural to them, much like the clinical work that we do. So the answer to that is no, there's not a difference in the research that you can do. There's MDs that do basic research. There's MDs that do translational research. Some of them have a PhD, some of them don't. I don't have a PhD. But I think in terms of what skill set you have when you start, I think you're more well equipped if you have a PhD and have done some extra time sort of honing your expertise. Because right now, for my research, I am finding myself, I'm going to have to take courses in flow cytometry, which I'll take through the NIH and things like that. I'll have to learn about single cell RNA sequencing and how to analyze that data and what the data means. Whereas if you incorporate all that into your PhD training and postdoc training, that's already done. And when you start as an employee, you hit the ground running. And really all you need is mentorship to help you along the way. So that's the real difference, I think, is the tool set that you arrive with, not necessarily the nature of the research. The tendency is for more clinical people to do clinical research or translational, but that's not necessarily always the case.
Thank you so much for that answer. One question is that we have a couple pre-physician assistant students here too.
Okay.
And a question is like, as like a physician, how do you, how is your relationship with a physician assistant, and what is like your perspective working with a physician assistant?
So physician assistant, I think, is one of those things that you need, because let's look at it this way. For me, most of what I do, I don't need all the training that I've had, to be honest with you. Yeah, to do the operations, you need the training. Yes, to make a really complicated multidisciplinary session or multidisciplinary decision, yes, I probably need that training. But for most follow-ups, for most surveillance, for most, relatively straightforward issues, or at least as straightforward as it can be for pancreas and liver, imaging follow-ups, a PA or an NP can do 99% of that. And to be most efficient in using your expertise, that's how you have to use a PA to delegate. Like the PAs, one second. But yeah, that's how I think PAs are most useful, is when you can just split the work essentially, and do things together and work together. And so I think they're tremendously beneficial because they have high levels of expertise, especially if you train them to be that way. And like I said, they can do most of your job. They practically make me worthless. So I have a very positive view. There's only one PA that we work with right now. Her name is Janelle Kelly. She is awesome. I don't spend a ton of time with her because she's serving 6 of us right now, but that's just because she does a lot of inpatient stuff, and then she does a couple of follow-up clinics, and that's what she does. But I think PA is a great career to go into. Very reliable hours and a very specific job. Sometimes some of the stuff that I do, it's a little bit more, there's a lot of unspoken portions of your job. Call, responsibility levels sometimes, adding in the research, adding in the education component, educating people and teaching people. A lot of that also gets thrown into my job, and PAs can do that as well. The really good ones do all of those things as well. They might do it, they'll participate in research. They may not do it, they may not do all the groundwork, but they help recruit patients. They help analyze data. They sit in on the meetings and come up with ideas. They get published as co-authors on these papers. The good ones will educate medical students. They'll educate the residents. They'll put the residents in their place when they think they know too much. So I think PAs are great. I don't think the world of medicine can do without mid-level providers right now.
Okay, another question, since you spoke about mentorship, like as a pre-medical student and also in research, what makes like a really good mentor, and what's like some unforgettable experiences that you've had with some of your mentors?
Yeah, so mentorship is a really hard thing to get a gauge on, because what you need, the first thing is for mentorship to work best, you need to know what you want from that mentor. And so before you even go out and look for a mentor, the best thing to do, it doesn't matter if you already have, that doesn't mean you have to quit, but the best way to do it is think about, all right, I need a mentor. What do I need a mentor for? What do I want them to provide me? Do I just need somebody to talk to on a regular basis? Do I need somebody with specific expertise in XYZ? Do I need somebody just to read an abstract for me and give me feedback? Do I need somebody to serve as a clinical mentor and help you develop the maturity of your decision making and your emotional maturity and how you deal with complications or difficult scenarios? Like, mentors can serve multiple roles, and you can have multiple mentors. So you have to just figure out what kind of person you need at this time. And maybe the mentor that you need at this time is somebody who can put somebody just to talk to about career options. And when you go out and you reach out to these mentors, you just start looking people up or asking somebody you know if they know of anybody, and then you start contacting them. But you contact them with the specific question. Hi, such and such. I am such and such. I have these interests. I'm thinking about going to medical school, and I have strong interest in gaining mentorship in, essentially career development. I need somebody to talk to that can talk to me about choosing my career and deciding on whether that's a good choice for me. And the mentor is going to tell you if they can do that or if they can't. And a lot of times if they can't, either because they don't have time or they don't have that expertise, they usually know somebody who does. And that's how you get yourself a good mentor. That's exactly how I did it when I was an undergrad. And my best mentorship experience that I've ever had probably was that undergrad relationship. And the reason being is that person who no longer works at the university because they retired a while back, was able to mentor me through essentially my career choice and solidify it, because we just talked all the time. And the key to that mentorship relationship wasn't even the fact that I did research in his lab. It was more, he clearly became the mentor that was kind of more of like your friend. Somebody to talk to, somebody to bounce things off of, somebody to talk about kind of anything with. You need to have a mentor like that who can be your friend. So that's the one that that resonates most with me, that's been most my friend. I would say probably throughout all of my training was when I was an undergrad. Because every mentor since then has been more specialized and has served a very specific purpose. Whereas that guy was really the only one that was just I can go talk to him anytime mentor. So that is a whole can of worms you can open. 1 second. I have, I'm looking for a book that I have. I have a book basically that's about academic medicine. And there's a whole chapter about how to pick your mentor. And I basically summarized it very briefly, but that goes into excruciating detail on it. And then the way you be a mentee is you just have to always know what you want. Or if you don't know what you want, you have to be able to verbalize maybe why you're having trouble figuring out what you want so that that person can help you with it. But you need to have specific things that you're asking them for. And if you agree to do something, you have to stick to it. You have to stick to your timeline. You have to stick to your whatever. You have to hold up your end of the deal. You don't just want to use them for gain and then not follow through.
One question that we got is before surgery, how do you prepare yourself mentally and like basically how do you prepare yourself before surgery? Like
so there's a few things. First of all, the more surgeries you do, the less, what do I say? You're always worried and you're always nervous. There's a little bit of unknown with any surgery that you go into. And I don't think that ever changes throughout your life. What changes is that you just are used to feeling that feeling every time you go into the operating room. And you've done it for a long time. And, you know, when I started, before I did my first huge pancreas case or liver case, I didn't sleep the night before. I sleep just fine now, and I'm only a year in. Like you just learn to deal with it. What I say is you have to deal with the mental aspect of the unknown and, you know, being nervous for something, you know, when the time comes. Don't let it ruin your sleep. Don't let it do all those things. But that comes with time and experience, and that's something all of you, when you first start, are going to experience, is that unknown and the nervousness, just like you do with anything in life, honestly. But preparation wise, that's how you get rid of some of the nerves. You need to really apply yourself in training. You don't want to go through your training and do just well enough to get through. Really try and learn the craft. Really try and understand and immerse yourself, because even though it's a painful few years, it's years that you'll never get back. And if you don't really apply yourself, you're going to be behind forever. So you really have to use your time and training when you get to it to really focus on things. And I'll be honest with you, when you go through training, you can't maintain every aspect of your life the same way that you can as an undergrad student or as an attending now, like I am. Because so much of your time will be taken by training and by sleep, that you're going to have to pick the few things in life that you just have to do. You're going to have to get away for vacation a few times a year, and you have to pick what's most important that you maintain. And maybe that's health and, you know, interaction with family. And that has to be it. It's hard to do everything well. There are some outstanding individuals that I feel managed to be incredible physicians and be able to seemingly do everything. They were part of this club and that club, and they were biking and riding and canoeing and climbing Mount Everest. And it was like, Jesus, how do you do that? But for most people, you can't do all of those things. You have to pick the things most important to you, and the rest of your time, you really have to focus on honing your craft. Because for me, for surgery, if you didn't train well and you're not ready to be an independent surgeon, there is no worse feeling standing over a patient that's asleep than that. So you have to be ready from your training, and you need to really understand anatomy, and you really need to understand the imaging that you obtained prior to workup, and you really need to understand the biology of the cancer that you're treating. And once you understand those things and you develop a review routine, which I do the night before every surgery, then, like I said, you start being able to realize, okay, this is going to be really difficult. I'm going to deal with it in the morning. I'm prepared. I'm ready to go. I'm going to get some sleep. I'm going to get up. I'm going to have some coffee, and I'll worry about it then. And that's when you do it. And it's interesting, just like with really any competitive sport or anything like that, the nervousness goes up until it starts. As soon as you make the incision, that's over. And from there on out, it's all concentration and focus. So that's how I prep for a surgery. It's looking at imaging, history, and physical, making sure I understand the anatomy. I've already been well prepared. The pre-prep and training is something. 1 second, guys. Okay. All right. So that's what I would say.
Okay. One that we usually ask is, what's one thing you kind of wish you told you knew like before you kind of started this, like one helpful like piece of advice that you think that would like you kind of learned along the way, but it would have been nice to know like from the beginning of your journey?
Yeah. I can't say there's something that I didn't know, but there's something that you do never understand until you get there, is really it never leaves you. Medicine never really leaves you. I've gone on a couple of vacations this past year, and I've gotten paged to my cell phone, or somebody has called me, or somebody has texted me about some clinical thing on every vacation that I've gone on. And that's just the way it is. Medicine continues without you, and it will always intrude into your life, but you just have to be able to, in the times when you're trying to be away from work, you just have to be able to divert that. But that's hard. So basically what I'm saying, I wish I understood, is how much commitment and how much it seemingly takes away from others around you, particularly if you're not careful. And I'm not saying that to deter anybody, but it's a career that, like I said, it can very quickly swallow you and take you away from everything that you love. And it's really important to understand that the temptation is always going to be there. And again, you just have to learn when to delegate and when to say no. So when you're on vacation and you get a call about some consult, you have to be able to very easily and very calmly, without any stress. And it seems easier now, honestly, as an undergrad than once you go through all of your training. Like I said, you'll feel like you have to do all of this stuff. But you need to be able to say on vacation, I'm out of town on vacation. I have a partner who can handle this issue for you. Here's their number. Bye-bye. See ya. And don't talk anymore. You just have to be able to take 5 minutes to do that and fix the situation and move on. And if you take vacations, the little secret is if you take vacations where your phone doesn't work, that's the best, because then the temptation's not there. But it'll always intrude. People call you at night sometimes. On the weekend, you might get a call when you're not on call because you have expertise in a certain area and somebody wants help. But there's always something, and you just have to be able to draw the line.
One question we're also getting a lot is, so I'll just ask a specific question. It says, family seems something that's clearly very important to you. How did you approach important decisions like to get married or start a family?
You just have to do it on your watch and not somebody else's. I know that seems overly simplistic, but try not to, and it's easy. I hate to say it in this world, these decisions, unfortunately, sometimes are different for females, particularly ones that want to get married and have a family. And unfortunately, even though everybody preaches, gender equality and this and that and the other thing, the fact of the matter is there are still people in every institution where, even though they might not outwardly say it, they discriminate against that type of thing. This lady's, this young, smart woman is so interested in surgical oncology, but she also seemed very interested in having a family. Maybe we'll take somebody else who's not so interested in having a family. And they don't say that outright in like their selection committees or things like that, but that process goes through their mind. And unfortunately, it's still prevalent. I saw it through my surgery training, even though I thought UCLA was awesome. I thought they were as good as anybody at equality issues, but still those things prevailed. Some of those thoughts prevailed, particularly in the older faculty members that, don't share a lot of the same values that we did. And a lot of that's because they project the hell and the terrible training that they went through on everybody else. But family, you just have to make important. Don't care what other people think, and you got to do it on your time. Don't say, oh, I want to finish medical school first because that seems like a good time to get married, or that seems like a good time to have a kid. There's no good time to have a kid. I can tell you, no matter when you have them in your life, they take an insane amount of your time and mental energy. And if having a kid is something you want to do, you have to decide when it's right for you based on you, not a milestone in your life. So, my wife and I had kids during residency, and we just did it. Because otherwise you wait till now, and I'm, 37 years old. She's 37 years old, and, things are started late. So that's what I say. You just have to do things in your own time. Get married when you want to get married. Have kids when you want to have kids, whatever it may be. And don't care what anybody else thinks, because that's none of their business. And in the long run, that's what's going to keep you healthy to do the job. So that's what I would say.
Thank you so much for such an honest answer.
Yeah.
Here's also one question is, we know technology is kind of like taking over the world. How is technology taking over specifically oncology, like surgical oncology?
There's a lot of different things. One huge thing in surgical oncology is personalized medicine. We've gotten so good at genetics now that we're doing these incredibly complicated genetic profiles of so many different patients on the same tumor type, and we're able to correlate those with outcomes. And they're turning these genetic discoveries into lab experiments and mouse models and clinical trials. And every day we're developing more and more targeted therapies that have very little toxicity compared to traditional chemotherapy. And part of the area of targeted therapy is the immune therapy revolution. I think it's the biggest development in oncology. And I think that's where all the hot research is going. It's going to be towards personalized medicine based on your genetics and targeting the immune system. That's where I honestly think the field is going. It's not going to be in a device. There's plenty of devices and fun things to use for ablation and irreversible electroporation and different types of radiation with proton beam or standard beam. There's a ton of technology involved. Like I said, the thing that's going to make the difference is the personalized medicine revolution dealing with specific gene mutations and immunology. That's where it's going. And I think I got to add a thing on. For surgical oncology, I think what that's going to lead to is operating on more and more patients. I think one thing that people worry about is if your medicines are so good, you won't need surgery anymore. But I think it'll be the opposite, because I think a lot of advanced stage patients with metastases are going to become operative candidates for cure because of these therapies. We may start taking out metastases for pancreas cancer where we never did before. So that's where I think it's going, and I think it's super exciting.
This is gonna be the last question. It's more of like a fun question we like to ask the doctors.
Okay.
There's so many like medical dramas happening, like Grey's Anatomy, Scrubs. As an actual surgeon, an actual physician, how do you like? What's your like opinion on them? And how are they like? I know some of them are like very inaccurate, but like how do they portray them right, wrong?
Well, I watched the first 2 seasons of Grey's Anatomy, and just for being a drama and entertainment, there's nothing wrong with them. I enjoyed the show. If you go at it from the perspective of how accurate is it medically, it'll drive you insane. That's part of the reason I don't watch them anymore, is I found myself unable to see it for what it is. And I always, like on Grey's Anatomy, you ever notice they're always operating when it's dark in the room? Like, how do I see? Do I just operate blind? It makes no sense. Like, all the lights are going to be on in the operating room unless you're doing like laparoscopy. And the other thing is they dramatize. They're accurate with a lot of the medical conditions, but they dramatize it. So it's like somebody's stuck in a cement slab. Somebody's stabbed with a 16-foot long rod. It's stuff that doesn't happen that often, as opposed to more routine problems. But I don't mind the shows from the standpoint of drama.
Well, thank you,
Anything
everyone.
else?
Maybe is there any last one you can think of? Oh yeah, one kind of a repeated question was, how has kind of COVID affected your specialty in terms of surgery, and how it's kind of either like set you back or how you've kind of adapted to it?
Early on, it didn't change a whole lot, because what Fairview did is they went to anybody that didn't need in-person visits, we would do with a video visit. So some of the formatting changed. I did a lot more video visits than in person. Now it's mostly gone back to in person with a few video visits. So it changed the forum in which my clinic occurred. It changed the way we rounded in the hospital, because we were only having one of my partners, round. We would switch off on a weekly basis so that only one of us was rounding on all the patients. Surgeries didn't change, because oncology surgeries are all tier 2, meaning they need to be done. So we weren't having trouble with like some of the laws that went out about not doing elective surgeries, because no oncologic surgery is elective. So that didn't get hurt. What did hurt is a lot of the routine screening stuff that picked up cancers. So the referral base dropped off massively for a couple of months. But now it's picked back up swimmingly, and we're as busy as ever. But those are like the biggest things, I would say.
Right. Well, thank you everybody so much for coming. Thank you, Dr. Ankeny. You gave us a lot of important information, and it was very helpful, and thank you for taking the time to
Yep.
answer our.
Keep your family and friends forefront, whatever it is for you, because I know not everybody has tons of friends and not everybody has a strong family. So whatever it is in your life that's core, you have to keep that there, and this will be an easy career for everybody. Otherwise, it's not so easy. All right.
Okay.
All right. See you guys.
Okay. Yep. Thank you so much.
Yep. Bye.
We're also having one next week. What I forgot the time and date and who it.
Yeah, we're having 2 next week, 1 next Monday and 1 next Tuesday. We'll email you guys and keep you up to date. So don't worry about that. So, okay.